And now we're up to the clinch hitter for today, which is Dr. Daryl Zeldin, and batting cleanup, I should say.
All right. So as I said, it's a hard act to follow Charlie and Bruce and Deepak. All right, so I'm going to talk about bioactive lipids and COVID-19 infections. So first of all, I want to make a disclaimer. I'm a co-inventor on several patents on the use of SCH inhibitors for the treatment of hypertension, inflammation, and related disorders. So my lab focuses on the role of eicosanoids and other lipid mediators in cardiovascular and pulmonary diseases. Various stimuli, including viral infections, can induce phospholipase A2 to release arachidonic acid from cell membrane phospholipids. And arachidonic acid can then be metabolized by several enzymatic pathways. Cyclooxygenases 1 and 2 and secondary synthases produce a series of prostaglandins that have a number of variety of important bioeffects. Cytochromes P450 generate compounds called epoxyeicosatrienoic acids, or EETs, which are further metabolized to dihydroxyeicosatrienoic acids, or DHETs, by soluble epoxide hydrolase. And several lipoxygenases convert arachidonic acid to leukotrienes, lipoxins, or heats, also called hydroxyeicosatrienoic acids. And all of these metabolites signal through G-protein coupled receptors, by transactivating nuclear receptors, or by activating ion channels to elicit a number of potent biological effects that could directly impact the pathogenesis and progression of COVID-19, as you've heard earlier from both Deepak and Bruce. For example, COX-derived prostaglandins can be either pro-inflammatory or anti-inflammatory, either vasodilatory or vasoconstrictive, and either pro or anti-thrombotic, depending on the specific prostaglandin. In addition, they can regulate differentiation and function of many different immune cell types, including T cells and macrophages, which are important in COVID pathogenesis. The P450-derived EETs have potent anti-inflammatory effects. They also have important pro-resolving effects, or vasodilatory, and have anti-thrombotic effects. Lipoxygenase-derived leukotrienes are generally pro-inflammatory, known to induce bronchoconstriction and recruit immune cells to the lung. And lipoxygenase-derived heats have a variety of biological effects, but are generally also thought to be pro-inflammatory and chemotactic for various types of immune cells. So all of these actions are potentially important in the pathogenesis of COVID-19, which is characterized, as you've heard earlier, by uncontrolled inflammation and thrombosis. So given their known roles in regulating inflammation and immune cell function, several eicosanoid pathway inhibitors have been proposed for the treatment of COVID-19. For example, dexamethasone inhibits phospholipase A2 release of arachidonic acid, and it's been used to treat a variety of inflammatory disorders, including COVID-19. Both Xylutin and montelukast work on the 5-lipoxygenase pathway and are used clinically to prevent inflammation and asthma. Non-steroidal anti-inflammatory drugs, or NSAIDs, inhibit the cyclooxygenases and are generally used to treat a variety of inflammatory conditions. And SCH inhibitors block the conversion of the anti-inflammatory EETs to less active diols and promote resolution of inflammation. And we believe these SCH inhibitors hold promise as novel treatment of COVID-19, and this will be the focus of my talk today. So there's really very limited data in the literature on the use of eicosanoid pathway modulators in COVID-19. For example, the effect of COX-2 inhibition in a mouse model of SARS-CoV-2 infection was just published last month in the Journal of Virology. COX-2, or PTGS2, expression was increased after SARS-CoV-2 infection. And the COX-2 inhibition with the selective inhibitor meloxicam attenuated production of the pro-inflammatory cytokine, TNF-alpha, but it also suppressed induction of anti-inflammatory, antiviral cytokines such as interferon-γ. And in the end, COX-2 inhibitor failed to prevent weight loss and mortality in the SARS-CoV-2 infected mice, and the authors attributed this failure to a deficiency in neutralizing antibody production and a subsequent increase in viral burden. A very small, uncontrolled retrospective study of cystenyl leukotriene receptor antagonist montelukast in COVID-19 patients was published a couple of months ago in the Journal of Asthma. And this study, which only included 92 subjects, found that individuals given montelukast on admission were 2/3 less likely to have clinical deterioration than individuals who did not receive montelukast, and that was statistically significant. But again, this was a small retrospective study. As I mentioned earlier, Cytochromes P450 can metabolize arachidonic acid to anti-inflammatory EETs, and then soluble epoxide hydrolase metabolizes those EETs to less biologically active diols. Cytochromes P450 can also metabolize linoleic acid to epoxides called EPOMs, which are thought to be the less biologically active compounds, and become activated to pro-inflammatory diols called dihomes by the epoxide hydrolase. So EETs attenuate LPS-induced upregulation of TNF-alpha in monocytes in vitro. This is an example of their anti-inflammatory effects. In contrast, EPOMs fail to induce TNF-alpha in vitro, whereas dihomes potently induce TNF-alpha, so are pro-inflammatory. Likewise, EETs and dihomes have been shown to regulate lung immune function in vivo. So endothelial expression of CYP2J2, which is an enzyme that produces EETs, protects mice against LPS-induced lung immune cell infiltration. In contrast, intravenous injection of 9,10-dihome causes rapid and severe pulmonary edema and immune cell infiltration in the lung. So anti-inflammatory versus pro-inflammatory. There's little published evidence for the involvement of soluble epoxide hydrolase, EETs, or dihomes in COVID-19 per se. A proteomic study of human plasma from COVID-19 patients found that levels of SEH on admission correlated with disease severity, with increased SEH levels in the most severely affected individuals who were hospitalized on ventilators. Su and coworkers found that plasma levels of 9,10-dihome increased with disease severity in hospitalized COVID-19 patients. And in a separate study published earlier this year, both 9,10 and EPOM and 9,10-dihome were found to be increased in a small cohort of severe COVID-19 patients relative to control patients without COVID. So since SEH removes the anti-inflammatory EETs and produces pro-inflammatory dihomes, SEH inhibitors have been proposed as a new class of anti-inflammatory drugs. And several SEH inhibitors have been developed, including the urea-based inhibitors TPPU and APAU, which were synthesized by Bruce Hammack, a drug from GlaxoSmithKline called GSK 225629-4A, and a drug from Icosis called EC5026. Three of these soluble epoxide hydrolase inhibitors have been studied in humans in phase 1 clinical trials and found to be safe, and all of them have shown to be effective in vivo in increasing EETs and decreasing dihomes. So during SARS-CoV-2 infection, as both Deepak and Bruce showed earlier, there's an upregulation of genes, including cyclooxygenase 2, and 12 and 15 lipoxygenase that lead to an eicosanoid storm with production of pro-inflammatory prostaglandins, leukotrienes, and heats, which leads to the cytokine storm, which is production of pro-inflammatory cytokines such as IL-1 beta, IL-6, and TNF-alpha, which leads to the widespread inflammation that's characteristic of COVID-19. Moreover, the cytokines can amplify the cascade by upregulating COX-2, which then leads to uncontrolled pro-inflammatory cycle. So the concept here is that by increasing anti-inflammatory EETs and decreasing pro-inflammatory dihomes, the SEH inhibitors would potentially attenuate the inflammatory response and stop this vicious cycle from occurring. And so we hypothesized that SEH inhibitors can protect against SARS-CoV-2-induced icosanoid and cytokine storms and hence improved clinical outcome. And so our objective was to evaluate the effect of SEH inhibition in a mouse model of SARS-CoV-2 infection. So for these studies, we used the K18 humanase 2 transgenic mouse in a SARS-CoV-2 model, which was published by Winkler in Nature Immunology last year. In this model, mice which overexpress the human form of SARS-CoV-2 receptor ACE2 in the airway epithelium exhibit an early day 2 peak in viral load and production of pro-inflammatory cytokines, including IL-1 beta, IL-6, and TNF-alpha. By days 4 to 7, the viral titers and the cytokines are decreasing, as you can see here, but the mice continue to lose weight and they develop severe pneumonia, and nearly all the mice die on days 7 or 8 from the viral infection or from the uncontrolled inflammatory response to the virus. Unpublished data on the regulation of eicosanoids after SARS-CoV-2 infection comes from our collaborators, Katie Bazio and Benji Schwartz from NIAID in Rocky Mountain Laboratories in Montana. And they treated K18 humanase 2 transgenic mice with SARS-CoV-2 in a BSL-3 facility, and they assessed lung oxylipids by LCMS on days 0, 2, 4, and 6. And you saw some of this data earlier in the symposium. So the COX-derived prostaglandins in lung of infected mice showed a biphasic pattern in this study where PGE2, PGD2, and the stable prostacyclin metabolite, 6-keto-PGF1 alpha, all were increased on day 2 post-infection, then went down, and then increased again as the mice developed severe pneumonia on day 6. The pattern for the lipoxygenase products was more variable. For example, lipoxin B4 was increased on day 2 and to a lesser extent on day 6. 15 heat was increased only on day 6, whereas resolvin E1 appears to have a biphasic response similar to the prostaglandins with increases both on days 2 and 6. The pattern of 14-15 ET was similar to that of the prostaglandins with a biphasic response, although the small increases on days 2 and 6 were not statistically significant. The 14-15 DHET, the soluble epoxide hydrolase product, is largely unchanged early in the course of disease, but increased dramatically on day 6. Importantly, the EET to DHET ratio, which is a marker of soluble epoxide hydrolase activity, was reduced on day 4 and day 6, consistent with increased SEH expression and activity. The dihome pattern was very similar to that of 14-15 DHET, with a substantial increase on day 6 post-infection, again, consistent with increased SEH activity. So together, these data suggest that SEH might be involved in SARS-CoV-2 infection and inflammation, and that SEH inhibitors may in fact be beneficial. So we infected the K18 humanase 2 transgenic mice with 6 times 10 to the 3 colony-forming units of SARS-CoV-2 intranasally in a BSE-3 facility at Battelle. And we treated mice with either a vehicle or with the SEH inhibitor TPPU beginning 2 days prior to infection. And then we studied 10 male and 10 female mice in each of the treatment groups. And we sacrificed uninfected control mice and both vehicle and TPPU treated mice on days 5 and day 7 post-infection. And we currently have data on survival, on weight loss, and on plasma oxylipins by LCMS, whereas data on the viral titers, histology, and cytokines are being generated as we speak. So as shown earlier, mice begin to lose weight on day 4 post-infection and continue to lose more weight before succumbing to infection on days 7 to 8. Importantly, TPPU significantly attenuated the weight loss, which is a clinical sign of disease in this model. On day 6, vehicle-treated mice lost 14% of their body weight, whereas TPPU-treated mice lost only 8% of their body weight on average, and these differences were statistically significant. However, TPPU did not produce a significant survival benefit in that 40 to 50% of the mice died on day 7 post-infection in both groups. And this is not unusual in this model of SARS-CoV-2 infection in mice. In fact, there's been very little or any therapeutics other than antivirals that have been shown to affect survival. Assessment of the plasma oxylipids confirmed the efficacy of SEH inhibition. So vehicle-treated SARS-CoV-2 infected mice had a small but significant increase in 14-15 EET on day 5 and on day 7, and a larger increase in 14-15 DHET on day 5 post-infection. Thus, the EET to DHET ratio was reduced significantly on day 5 post-infection, consistent with increased SEH activity. Importantly, treatment with TPPU significantly increased 14-15 EET and decreased 14-15 DHET, and the EET to DHET ratio increased significantly on days 5 and 7, consistent with inhibition of SEH. Similar changes were observed for 11-12 and 8-9 EETs and DHETs in data that I'm not showing. Likewise, vehicle-treated SARS-CoV-2 mice had a significant increase in 12-13 dihome on days 5 and 7 post-infection, and treatment with TPPU significantly increased 12-13 EPOM and decreased 12-13 dihome, and the EPOM to dihome ratio increased significantly on days 5 and 7, again consistent with inhibition of SEH. Similar changes were observed for the 9-10 EPOM and dihome in data that's not shown. So taken together, these data show that SEH inhibition with TPPU increases plasma levels of the anti-inflammatory EETs and decreases plasma levels of the pro-inflammatory dihomes after SARS-CoV-2 infection. We also observed significant attenuation of the eicosanoid storm after SARS-CoV-2 infection. So compared to uninfected mice, vehicle-treated infected mice had increased plasma levels of PGD2 and the stable thromboxane metabolite, thromboxane B2, on days 5 and 7 post-infection. And TPPU significantly attenuated the increase in PGD2 on both days, and a similar trend was observed with thromboxane. Note that we don't think that this is a direct effect of TPPU on cyclooxygenases, but rather reflects a suppression of the cyclooxygenation induction after SEH inhibition due to effects on pro-inflammatory cytokines. And we hope to confirm this in the near future by measuring cytokines in these animals. SARS-CoV-2 infected mice also displayed increases in plasma concentrations of 15 heat, 12 heat, and LTB4 on days 5 and 7 post-infection, and TPPU treatment significantly attenuated these increases on day 5, consistent with the reduction in plasma levels of these pro-inflammatory eicosanoids after viral infection. So in summary, during SARS-CoV-2 infection, SEH activity is increased, resulting in decreased anti-inflammatory EETs and increased pro-inflammatory dihomes. There's upregulation of genes including cyclooxygenase 2, 12-lipoxygenase, and 15-lipoxygenase that lead to an eicosanoid storm with increased production of pro-inflammatory prostaglandins, leukotrienes, and heats, which lead to the cytokine storm with increased productions of pro-inflammatory cytokines such as IL-1 beta, IL-6, and TNF-alpha, which leads to the uncontrolled inflammatory response, significant weight loss, and ultimately death of the animal. SEH inhibitors lead to significant increase in plasma levels of the EETs, the anti-inflammatory EETs, and decrease plasma levels of the pro-inflammatory diomes, which attenuate this inflammatory response, limit weight loss, and therefore SEH inhibitors have beneficial effects in this model of SARS-CoV-2 infection in mice. And so our immediate future directions are to examine lung cytokines by qPCR, viral load, and lung histology in the samples from this experiment that I showed. We also hope to determine if SEH inhibitors confer a survival benefit in less severely infected mice. In other words, mice given a lower viral load. In addition, we think that timing of SEH inhibitors may be important. As COX-2 inhibitor studies in mice have shown, and human studies with corticosteroids have shown, treatment with anti-inflammatory drugs during early infection may be more harmful than beneficial. We also plan to test the effects of the EET blocker or antagonist 1415 EEZE to determine whether the beneficial effects of SEH inhibitors are due to the increased EETs or the reduced diomes or both. We also have plans to measure serum oxylipids in patients with mild, moderate, and severe SARS-CoV-2 infection, and to examine the effect of polymorphisms in eicosanoid metabolizing genes on clinical outcome in COVID patients. And lastly, we hope to test the efficacy of these SEH inhibitors, which have been proven to be safe in humans in phase 1 trials, in phase 2 clinical trials for the treatment of SARS-CoV-2 infection. So with that, I'd like to thank the members of my lab at NIEHS, our colleagues at NIAID in Montana, and Bruce Hammock and Christoph in his lab for providing the SEH inhibitors. And I thank especially Charlie for organizing this wonderful symposium, and I'm happy to answer questions now or during the panel discussion. Thank you.
Wow, Daryl, batting cleanup, you really hit a home run there. That's really a nice presentation. I have to emphasize before we start and go into the panel discussion that you each know the eicosanoid literature well, so you know that lipid mediators antecede, they temporally come before cytokines, and they also do this evolutionarily. Obviously, small molecules, lipids, they came first before the cytokines. And since so many people have heard all about cytokine storms forever as the importance in this disease, I think it's really critical that in your studies, Daryl, you really did nice time course studies and showed biphasic responses. And those biphasic responses may be particularly amenable to therapeutic manipulation with lipid mediators themselves, as you point out, or specific inhibitors. So I have to ask you, do you think that the SH inhibitor has a target in airway epithelial cells? Do we know if there are soluble epoxide hydrolases within the epithelial cells in the airway?
So there are, we can detect low levels by PCR in airway epithelial cells. They're obviously in endothelial cells as well. The specific cell types that are producing the EETs and then degrading the DHETs is probably less important because these mediators, as you know, are freely soluble. So they can be produced in one cell and act in a paracrine fashion on other cell types, or they can be produced locally and act in an autocrine fashion on an individual cell type. So yeah, I think it varies, and it may also be variable by species. So for example, in humans, we believe SEH expression in the airway is more abundant than in mice, in mouse airways. So I think. Yeah.
No, yeah, that's really important that you bring that out, because people tend to forget, general audience, that these are autacoids. They're local acting, and what we do measure at a distal site could have a biological impact, but it may not necessarily. So, I would, when I first think of soluble epoxide hydrolases and inhibitors, I always think about the liver, because I know very little about the liver. So do you think that a main target could be liver and maybe some other site, distal site, that would then make levels that would be commensurate with regulating debris clearance and down-regulating the inflammatory circuit?
Yeah, I mean, certainly, liver is a source for EETs. I don't know that well-controlled studies have been conducted in tissue-specific SEH knockout mice, for example, to demonstrate the relative contributions of SEH in liver versus lung versus endothelial cells versus other tissues. Yeah, those we have the floxed SEH knockout mice that could be used to address just that specific question. We are breeding the floxed SEH knockout mice into the human ACE2 transgenic mice with the understanding that we'll be able to look at the tissue-specific effects of SEH in this model of SARS-CoV-2 infection. But obviously those mice are not available yet, but they'll be available within a few months, we hope.
No, that's nice. Yeah, I just noticed that there are humanized COVID-2 mice available from Taconics to do those type of studies.
Yeah, they're hard to get. There's a big demand for those mice. We actually developed using CRISPR-Cas our own human ACE2 knock-in mice, and so they're we have them growing now in our colonies.
So. In your future directions, you pointed out a potential, I guess, phase 1, phase 2. How would you, without spilling all the beans and showing the cards, how do you think that might look? What would the trial look like?
So I would think in a small phase 2A study, you would randomize patients to treatment with one of the soluble epoxide hydrolase inhibitors that's already been through phase 1 studies and shown to be effective. I would probably pick the epoxyeicosatrienoic molecule. And we would probably give it on admission to patients coming in the hospital with more severe disease, and then look at a variety of clinical outcomes. We'd measure levels of circulating levels of cytokines, circulating levels of eicosanoids. If they were intubated, we could do bronchoalveolar lavage and measure lavage levels of these and then the main outcome measure would be survival, morbidity, oxygen, need for mechanical ventilation, kind of the same endpoints that are currently being used in a lot of the other trials that are looking at efficacy of antivirals and some of the cytokine, the anti-cytokine antibodies so. And of course, I'd rely on people like Bruce Levy to recruit patients in his ICU, which is filled with ICU patients.
Well, yeah, Bruce, you mentioned this as well as Daryl in Benjamin Schwartz's published study. That group was able to see with the Yale samples clear differences in the peripheral serum levels of the mediators. I think they broke it down to severe versus moderate. So do you think, Daryl, that the moderate group, which I think had EETs and resolvents in the profile, could those be markers to then select people to then get an SH inhibitor to see if they could prevent them to go into severity?
Absolutely, that's one option. The other option is look at genetics, right? So we know there are polymorphisms in the soluble epoxide hydrolase gene that are associated with altered activity, and potentially you could screen genetically for the presence of that polymorphism, and maybe those people would be more likely to respond to SEH inhibitors, or like you said, you can measure EETs, DHETs, EPOMs, diomes, and target the SEH inhibitor to the low EET, high diome group, and that's another way to do a phase 2 study. It's a little more complicated because you have to get those results back quickly in order to start treatment. And you want to get the treatment started, I think, as early as you can in the process. Yeah, Bruce has to say on that, though.
Yeah, Bruce, go ahead.
Early, I think I'm not live yet,
Oh,
because I don't think we're at the panel discussion.